So basically today we have been doing ultrasound breast, mammography, as well as the MRI breast as well. So basically you want to see is a detailed image of the breast tissue and the accurate method of disease detection throughout the breast and the surrounding anatomy, including the lymph node. So the MRI breast imaging, it will be complement to the mammogram and ultrasound. Especially, it will be very useful for the lesion that only detectable under MRI. So this is the one. Stop. Okay. So only detectable under MRI, it will be very useful for the lesion, because it's unable to see under the ultrasound and mammogram, right? We got no choice for that. Just now also, speaker mentioned about angiogenesis. So it's an abnormal tumor vessels produced when the CS cell form, and it will move to the vessels and produce a new vascularity and become a cancerous cell. During this examination, this sharing session, I will cover the clinical breast MRI from the patient preparation, the equipment we are using, patient positioning, the breast lesion morphology, sequence and parameter that used under the MRI breast, MR post-processing, and also some case study that can share with you. So for the patient preparation under MRI, we will change the patient to the hospital gown, because MRI we are using magnetic field, right? So there is no matter at all. We practice in our hospital, we change from head to bottom. No matter what kind of scanning, we will just change the patient and remove all the external metal content item, including like dentures, or knee pin, bra as well. And also our doctor will do the MRI checklist, procedure consent, before we proceed for the examination. MRI contrast consent for the allergic history, like food allergic, maybe seafood, or medication allergic, asthma history, and also we check the GFR for the kidney function. We also set line for the patient if the contrast is needed, and also we will give for all the patient earplug to protect the hearing protection. For the MRI breast appointment, what we practice is we will schedule the patient from the LMP day 5 to day 12. Why we do so? Because we want to well visualize the breast tissue and structure. Beyond this period, right, due to the female, we will have like estrogen and progesterone. It will make it study interpretation a bit difficult, and the radiologist to avoid a false positive result in the reporting. So this is our practice, okay? This is what we practice here. So ideally, MRI breast is best avoided for patients undergo the hormone replacement therapy, HRT, pregnancy and lactating women. Is same thing, is because of the hormone changes. We scared of a false positive result. This is our GFR value chart, fighting level. If below 30, then normally we practice to not give a contrast to the patient unless the radiologist deal with the clinician, maybe undergo dialysis or any other method to make sure the gadolinium that is toxicity to flush out from the body. This is a earplug that we are using, and then this is a breast coil that we're using with a headrest, and then with the patient comfort pad, and also the breast coil, the breast plate attached together. For the MRI, unlikely like mammo, that we're going to compress the breast a bit, but this one, for the MRI, we just want to secure in position. We're not going to push until the max to compress the patient breast. So this is the contrast power injector that we're using. What we practice is we're using 10 to 20 mils contrast with a flow rate 2 mL per second and also flush with 20 mL saline. If we are not using the injector, then we'll be using the bolus injection or hand injection method. We will combine two together, contrast and also the saline. We will flush the contrast and then followed by the saline to catch the flow. Patient positioning, it will be in the prone with the feet first, the head will be outside, and then we make sure patient in comfort position. Because for MRI, it will take at least half an hour to 45 minutes for the examination. The patient comfortable level is very important. If patient cannot cooperate with us, then all the imaging will be out. And some of the breast is at the chest region. We want the patient to be relaxed, breathing relaxed as well. Then we can get the good image quality that we want. We'll put on the earplug or the music for the patient as well. This is how we position in the center. The MRI breast sequence and parameter that we're using is axial stir, axial T2 FSE. Axial stir mainly is a fat suppression, so that we, for the breast, there is a lot of fat structure inside there, right? So it will suppress the fat, then you can well visualize the breast structure. Axial T2 fast spin echo, coronal stir, and then diffusion weighted imaging and apparent diffusion co-efficiency. This is to see the restricted diffusion within the breast region or the lesion. T2 sagittal fast set for the right breast and as well as the left breast. Axial vibrant, this is a dynamic contrast enhancement that we will be followed from the mask phase as a baseline, then followed by 6 phase of the contrast continuously scanning. And also the single voxel spectroscopy to see the metabolic level. This is some of the sharing of the sequence and also the parameter setting. For the axial stir, this is how we're going to do it. And also the coronal. And this is sagittal. For the sagittal, we will be based on the nipple. We will align the nipple and do it sagittal for the right and left breast. For the vibrant dynamic contrast enhancement, so this one, as I mentioned, we will be doing one mask phase as a baseline for the breast, and then followed by the 6 dynamic continuously scanning for the breast, so that we're able to get 3 type of graph later on. Okay, so this is the one. We will do one mask phase, then followed by each of the sequence take about roughly 1 minute and continuously for 6 series. The first one will be mask, after that continuous by 6 series. Okay. So when we do the mask, it will be showing like this. This is the normal MRI breast that we scan. After that, we will do the contrast, post-dynamic contrast enhancement sequence. And then with the subtraction, then all the breast structure will be gone, only showing whatever is enhanced by the contrast. So for the breast lesion morphology, benign and malignant, today we also keep on emphasize on this, because this is very important in order we know what to see in the images, right? So for benign is minimal enhancement and very smooth border, lobulated border, homogeneous, and also non-enhancing internal substitution. It will be quite easy to differentiate. For malignant is very strong enhancing, you will definitely directly can see it. Speculated irregular border or the rim enhancement. Heterogeneous enhancing suspension. So one of the example is this. This is a very metaplastic carcinoma. You can see the ring enhancement is very obvious. Do you know why we see this and not the whole thing is enhancing? because for this case, right, necrotic in the middle of the lesion, which means it's a very strong malignant cell and causing ring enhancement with a very active CA cell. So this is a metaplastic carcinoma with a ring enhancement. Okay, so from there, after we done all the images already, then we can do a graph already. We are posting for the dynamic enhancement pattern, DC MRI of the breast. You will able get 3 types of the graph. So one of it is the washout. So this is the yellow color one. It will uptick and then wash out immediately. So this one most likely is a malignant, and then the other one is a red color one. It uptick and then become plateau. This one indeterminate, not sure whether it's a malignant or benign. And for the blue one, it will keep on progressive. So this one most likely is a benign. Okay, so you can see over here. So for the benign enhancement pattern, this is how it looks like. We will put in the lesion and then we calculate it. And this is also the benign one. This one we not sure because it's plateau. It keep on progressive and after that it plateau. So this is not sure whether it's benign or malignant. And this is most likely malignant because it uptick after that it wash out directly. This is also quite aggressive. It shows that it uptake and then wash out from the cell itself. Malignant enhancement. Okay. What if you see this? Because sometimes when we want to put in the ROI, right? Not all the cases we need to put in the ROI exactly follow the whole lesion enhancement. We already know that the active CA cell most likely at the side of it. It's not at the needle. Sometimes needle become a necrotic, so we need to maybe put a small ROI at the side of it, at the ring there, so that you will get a very good graph. And this one it enhance and then it go plateau. Then after that it go enhance again and go plateau. Why the graph will be like this? Because we put too many phases, 14 phases. So eventually 6-7 phases is good enough to show the characteristic of the lesion itself. So we don't need so many phases. Okay. And this one, same thing as well, because we put too longer time. Eventually, the first phase is a mass, and then followed by the 6th phase, we can see the flush out to determine will do. But anyhow, MRI, we cannot decide directly what is the benign or malignant of the cell. We always complement with maybe ultrasound, mammogram, or biopsy. Okay, and also another thing that is special for the MRI, we can see the vessels that supply to the malignant cell. We call that interactive vascular imaging. So after you take out everything, only the vascular able to see. So you will see very clearly. This is the malignant cell with all the vascularity supplied to it. Yeah, it will be very nice visualized under MRI. So just now is a very good interactive vascular imaging images. And another one is a breast spectroscopy exam. Normally we will do a single Watson spectroscopy. And also this is a non-invasive breast tissue assessment. We are not going to poke the patient breast or anything. We just scan on it and using the spectroscopy to check the metabolic level of the lesion itself. So we use a single detection technique to show the elevate concentration of the choline. Choline is a maintain a product of the membrane synthesis that rises in the rapidly reproducing the cancer cells. So mainly we are looking for the choline. It's a strong indicator of the malignancy of the cell. Okay. So this is how we're doing it. Okay. And you can see choline is at the 3.2 level. So from the 3.2, you can see the graph is high. Okay. So which means that one is most likely is a malignant cell. Okay. If it's not high, which means most likely it's a normal cell. From here you can see that the cyst and the normal parenchyma, 3.2 is this level. This is the line that we're going to see the choline level. This one there is no elevate of the choline. So it shows that it's a cyst of normal parenchyma, normal cell. Okay? As well as the fibroadenoma, okay, DCIS you can see already elevated. Infiltration ductal carcinoma, invasive lobular carcinoma, also got increased here, the choline level. Okay, this is some case study that I would like to share with all of you. Indication bilateral breast cyst Barrett's 2. Curie left axillary swelling related to the menses. Sequence that we are using is Axil T2, STIR, DWI, ADC, coronal STIR, the dynamic contrast enhancement, and the spectroscopy. This is the images that we get. This is quite done breast, okay? Then throughout the scan. This is from the DCE. Then we put the ROI on the enhancement lesion that we detected and show that this is a progressive. So which means this is not malignant, most likely, okay? And the clinical report that my radiologist reported is heterogeneous dense breast parenchyma pattern. More than 75% fibroglandular density is very dense breast that you can see just now. Almost symmetrical disrobed bilaterally. Maybe I can read and then you can refer here. So this one, both breasts also very dense breast, okay? No suspicious enhancing lesion. It's only one that we detected, and also we put in the graph. It doesn't show that it's a washout, so most likely it is not malignancy. It demonstrates progressive enhancement on the dynamic curve. So multiple small enhancing foci, less than 3 mm in size, are seen in the upper outer and lower inner quadrant of the left breast. So the impression is, appearance are suggestive of fibrocystic changes in both breasts. Enhancing left upper outer lesion may be inflammatory cyst or some small fibroadenoma. No suspicious axillary lymphadenoma, Barrett's 3. So we just follow up this patient with breast ultrasound or mammogram is recommended. Barrett's, just also they mentioned that Barrett's 0, no need any additional imaging evaluation. Barrett's 1 is normal MRI and normal ultrasound. Barrett's 2 and 3, it might be benign finding, but for Barrett's 3, you need some short-term follow-up just to make sure the lesion is remain benign, or maybe it might turn to malignancy that we don't know, right? So Barrett's 4 and 5 is suspicious and also most likely malignancy. And the Barrett's 6 is known malignancy, assure that the treatment is completed. For the case study 2 is the left breast carcinoma post-chemotherapy and also radiotherapy with a multiple recurrence for this patient. So we noted on the right axillary tail mass, can you show this? Sorry. Okay. So noted on the right axillary tail mass, biopsy show that it's an invasive ductus carcinoma. Ultrasound show that no breast lesion cannot detectable. So we want to rule out right breast lesion. The sequence that we're using also the same. This is our standard sequence for the MRI breast. So from here you can see that, okay, there is something here and also in the axillary region. And from the vascular imaging, we can see that there's very vascularity and also supply to the lesion. Okay? And this patient also is a recurrence patient. After we do the MRI, we also spotted some enhancement, everything. Then we put in the ROI, and the graph show that uptake and also wash out directly. It shows that it's a high malignancy of the lesion. So an irregular enhancing lesion seen on the left chest wall at the pectoralis muscle, and also there is multiple and enlarged enhancing right axillary lymph node. So as an impression, my radiologist reported as a left breast carcinoma post-mastectomy and also with the tumor recurrence of the left chest wall, and also metastasis to the right axillary lymphadenopathy. So thank you everyone for the MRI breast for the diagnostic. Come on.